taught us the mask was for our protection, but we're finding out that true safety starts when we take it off. I'm Gerron Scott, and this is Black and Diagnosed. This is a sanctuary for the mind, a space built for those navigating the world with labels like ADHD, bipolar, anxiety, and depression. We're moving past the clinical whispers to have honest conversations about our lived reality. Pull up a seat, catch the vibe, and join us in the garden. Welcome back to Black and Diagnosed. I'm your host, Gerron Scott, and today we're here with Stephen. We're going to allow him to introduce himself.
Hi, everybody. My name is Dr. Stephen Tourjee. I am a psychiatrist out in the Boston, Massachusetts area, and I'm also a child-trained psychiatrist, so I see children, adolescents, and adults. And I did my residency training at Harvard Medical School with Massachusetts General Hospital and McLean Hospital. And right now I practice part-time at the hospital at Mass General Hospital. I'm on the faculty at Harvard. And I also run 2 private practices in the North Shore of Boston.
Awesome. So you told me earlier that you grew up in California, Northern California, if I'm correct. And then you moved to Missouri. Compare the two for me. How was it going, that transition from California to Missouri?
Yeah, absolutely. I mean, I was pretty young when we moved from California to Missouri, and I was in Davis, California. So I was about 12 years old, just finished 5th grade when we moved to Missouri, mid-Missouri in Columbia, Missouri, for my dad's first job at University of Missouri, Columbia, after he'd gotten through graduate school. And I would say, honestly, one of the biggest differences was just like culturally, being in the Midwest, it was still a college town, Columbia versus Davis. I had received some warnings from like my California friends that like, oh, you got to watch out. Missouri's racist. Hey, you sure you want to go over there? I didn't really notice any overt racism. I thought people were pretty friendly in the Midwest. Honestly, I would say one of the biggest changes was just the weather. There was less immediate sunshine. There were more times that we had snow, which I had pretty much never seen before except for artificial snow. So it was a little bit more cold. The summers were a lot more humid and hot. And I felt like people were a little bit more, I think, a little bit more nice on like the surface level from what I saw. So if you had an issue with them, you'd maybe find out later. So there was like a little bit of less directness culturally compared to California.
Not ironically, but coincidentally rather, my first job out of grad school was down the street from Columbia at Lincoln University in Jefferson City. At the time, transitioning from mainly being in Georgia, and I always was in Atlanta. My school was outside of Atlanta, but always was in Atlanta during grad school, to Jefferson City, where I feel like there was 3 stoplights. Maybe they had more, but it felt like there were 3 at the time compared to Atlanta. And I love the people there. They were some of the friendliest people I met. I would say that about Missouri. The people there are very friendly, no matter who they were. I never felt that racism that you think you're going to feel when you move to a place like that. So that part I definitely agree with. So let's talk about this. So you were in California. Dad was getting his PhD. What was he getting his PhD in?
He was getting it in genetics, like environmental horticulture and like plant genetics, which UC Davis is really well known for their environmental horticulture and agriculture environment. That's why they're the Aggies. That's their mascot.
Oh, dope. So did that inspire you to reach for your doctoral?
I think so. I mean, I definitely would have to say my dad had an influence on me in terms of, math and science. He never really felt like he was that good at math as a child, and he was the first in his family to really go to college. So I think he instilled in us kids. I got 2 siblings that, we should work hard, and he taught us math, and he would give us additional work outside of school to make sure that we mastered the concepts. And, when I got through high school, I had more of a natural predilection towards like biology and chemistry and math, and, eventually settled on like wanting to be a doctor.
My undergraduate degree is in biology.
Oh, mine too.
Nice, nice. My master's is in professional counseling,
Oh, that's great.
concentration in student affairs. So I jumped all over the place. Had no idea what I was doing after undergrad. My PhD is in education. So I'm a little bit all over the place, but following my path, following my calling, somehow, some way, I got to where I am.
Good for you. Yeah, with an undergrad in biology, there's not a lot that you can do without graduate school. I mean, you can work in a lab, you can, maybe teach biology, but unless you get graduate school or like push yourself a little bit further, it can be limited. In
Yeah,
my opinion.
definitely. But I enjoyed it. I enjoyed more so the animal classes. I don't know if you took the class comparative vertebrate anatomy,
I did
but
actually. It's funny you mentioned that. I was a TA in comparative vertebrate anatomy. That was honestly one of my favorite classes.
same. People were like, that class is so hard. I was just like, I loved it. I
Yeah, I mean, it
absolutely
was challenging, but it was fun too. I mean, we dissected cats. We
sharks.
dissected, dogfish sharks. We dissected. What else did we dissect? I mean, I don't even remember. I just like maybe frogs. Um, and it was a lot. I mean, but it was so much more interesting than a lot of the other classes.
Okay, let me ask you this. What came first, the chicken or the egg?
Chicken or the egg? That's a good question. Um, I think the egg came first. Yeah, it was there. Um, and things evolved. I mean, I don't think that I'm not like against creation or anything. I'm Catholic, and I go to church every Sunday. But I also think the egg on a cellular level probably came first.
I like that. I like that. All right, before we get started, what is your favorite 90s show?
Um, ooh, that's a tough one. Favorite '90s show? I would probably have to say Family Matters.
Good, good
I would
one.
say either Family Matters or Fresh Prince of Bel-Air. I just always got a good laugh out of that, and we would watch it all the time.
Those are some good ones. So you alluded to a little bit, your dad kind of inspired you to get your doctoral degree, pursue further education. So on a personal note, what made you pursue psychiatry?
Yeah, it was actually pretty interesting because I had a pretty circuitous path. I initially went into orthopedic surgery. That's what took me back to Missouri after medical school at Vanderbilt. And but I felt like there was something missing from orthopedic surgery. Like it was just overly mechanical, and what I found myself enjoying more than talking about bones and muscles and how they moved was actually connecting with patients on a deeper level. I found myself more interested in like the psychosocial aspects of it and like how people grew up, why they thought the way that they did, how they were feeling about the experience, what their emotions were. And that was just so much more interesting to me in terms of like the development and having an impact on people's development in a different way. So I feel like both surgery and psychiatry are invasive, right? With surgery, you're cutting on people. With psychiatry, you're kind of invading into the mind and going deeper and dealing with more vulnerability. So for me, I just found the mental health field to be so much more rewarding once I switched into it. And it didn't feel as much like work and like a chore. It felt like I was cultivating something more meaningful.
That's dope because I love the way you put it. They're both invasive because in my mind, orthopedic surgery and psychiatry are very different. They're in vastly different fields. They're in different houses. So I'm glad that you made a connection between the two. Um,
Yeah.
so that transition, let's talk about that transition a little more. What really sparked that transition and how was that transition? Was it like, hey guys, I really want to do this, so you were just able to move over to it? Or were there like different boards and different certifications you had to do?
Yeah, I mean, it was definitely a little rocky. I'd be lying if I said it was all smooth. There's different paths to get to where you are. And, I went through all of medical school, did all the away rotations in orthopedics, matched in an orthopedic program, was there. And then I had decided to switch out of that. So, um, I met with a lot of different mentors at the hospital I was working at in Missouri, at Washington University in St. Louis, where I did my undergraduate. I went over there. So I saw a lot of consultation. I worked in a prison for a year in Missouri, 3 different prisons, taking care of the inmates. So after you finish 1 year of residency in Missouri, at the time, you could get your full medical license. It was no longer limited. So I was capable of getting my full medical license. I worked in the prison setting for a year, doing general medical care for the inmates, at a minimum security prison, medium security, and then finally maximum security prison at Jefferson City Correctional Center. That just rebuilt my confidence up while I applied to different residency programs in psychiatry. And I just applied to a lot of them. I probably applied to like every single psychiatry residency program in the country because I had no idea how people were going to perceive me or like my application. But it was received really well. And I'm thankful that, Harvard and Mass General Hospital, McLean Hospital gave me the chance to do my training with them.
Now look at you, a Black man on Harvard's faculty. That is so dope, right? I think what we can do as Black people is unlimited. Like the things we can do when we put our minds to it, it's fantastic. Like we are capable of so much. So let's talk about that. When you got that call from Harvard or the email nowadays, what feelings were inside of you?
Yeah, well, I mean, initially I wasn't sure if they were really interested in me, but I was getting like a lot of interviews at other like top places as well, like UCLA and Columbia, and Harvard circled back around and were like, "Hey, actually, we do want to interview you." I was I was over the moon excited. I mean, there were a couple colleagues that I had already from medical school that were already there, and I could see them and know that they were there. But I felt validated. I felt understood. I felt like people were seeing my potential, and it was almost like a golden ticket, was there. And I was like, let me see if I can take a shot at this, And my brother was already out in New Hampshire, living out here, so I was like, this is a chance to go back to the East Coast and be closer to him. And then my father is from New London, Connecticut, so he and my mom were going to be moving back anyway to Connecticut. So it was kind of like if I could get back here, not only could I train at an amazing institution, but be closer to family too. So I was pretty excited.
Definitely. The opportunity to be closer to family is amazing. I'm trying to get closer to my family. I've made it to South Carolina, couple steps away from Atlanta, but
Yeah.
closer. My family, New England, I love them to death, but, you know, it snows. So we'll see about getting closer to y'all. Maybe I always think when I retire, I might move back to Providence, but that's snow. They just got what, 32 inches or something like that. How many inches did y'all get during this blizzard?
I don't even know how many. I mean, honestly, we were on vacation in Aruba. Luckily, we timed it perfectly and got out right before the blizzard started and came back after. So I felt kind of guilty, but I was like, you know what? Uh, for the first time, I'm actually not stuck in the middle of the blizzard. But I think that was just luck.
There's no guilt to be had. You were warm.
Yeah, it was nice being on the beach, but they got hit with a lot. I mean, um, and it wasn't just that blizzard. I mean, there were a lot of other snow storms that we had, and just like because I remember having to deal with the snow.
Yeah. So let's take the gloves off. Black people just started talking about therapy in the past, like, it seems like 3 years that the word therapy was accepted by Black people. The word psychiatry and psychiatrist, that still turns some heads and makes people look away. They're just like, oh no, therapy's okay. You can talk about emotions, but now you want to actually talk about the brain chemistry and all those things. That's a whole nother story. So when you see a Black patient, how does that conversation usually go?
Yeah, yeah. I think when they first see me, that obviously I'm a person of color, I think that helps build a little bit of trust initially. But usually I think it just requires a little bit of more work in terms of building the trust and helping them to see that, we're not here to try to immediately diagnose or throw some medications at them. We're here to just start a conversation, and understand and listen and build from there. Because it's not just about treating symptoms, it's about cultivating an understanding of who that person is and really building on that journey. It's part of the reason I don't just do medication management like a lot of psychiatrists. I do a lot of psychotherapy that I blend with the medication management. We have other alternative and complementary treatments that are also FDA approved, like transcranial magnetic stimulation, which is a device-based treatment. So, and I use all types of psychotherapy as well, CBT, which is cognitive behavioral therapy, psychodynamic work. And so I think it just depends on who's in front of you, ultimately.
Yeah. I know with my diagnosis of bipolar disorder, it took a lot of sessions to even come up with that diagnosis. My psychiatrist was like, I don't want to diagnose you with something day one. I want to take my time, learn about who you are, what you've been through. And I appreciated that because I've talked to people, they're like, oh, I went to one psychiatry session. They said I have this. And I was like, that was very different from my experience. So typically, how does it work? Is it one session and it's like, hey, you have this, or is it a multitude of sessions? How does the diagnosis process work?
Yeah, well, it really depends. I mean, sometimes you can get a lot of information from somebody who sends you previous records, and they're a pretty good historian, so they can really describe a pattern of symptoms that's convincing and clear. And they might also have family or other like collateral supports to really back that up. But I think usually the way I practice, the way that it works is that first session is more of a consultation and a getting to know you and reviewing any records that they might send, whether it's neuropsychological testing, school reports, that kind of thing. And then over time, like even if I make a provisional diagnosis, like, hey, you might have ADHD based on what we're seeing, I'm still adjusting that over time. Maybe I think that after our first session, you might be dealing with some type of depressive disorder, major depression. But over time in our work together, we realized that that's not just regular unipolar depression. It's actually bipolar depression. And we find out that there was a manic episode before, or we find out that there's more of a substance use problem than we thought, with alcohol or weed, and that might be tying into it. So that diagnosis evolves and can be modified over time as I get a better understanding of who that person is in front of me and I get more data. And that's okay. That's how it is with a lot of things, not just in psychiatry, but like even, when you look at people that have high blood pressure or diabetes, right? It's not like they just write you for insulin right away and say, hey, take this insulin. It might be, well, you have some impaired glucose regulation. Let's get some more testing. Let's see if we can do diet and exercise, some lifestyle modifications, and then go from there.
Nice. Thank you. Let's talk about drug-induced mania. You mentioned that. So when you come across a patient as drug-induced mania, how do you have that conversation with them?
I see a lot of that actually, because I see a lot of young adults, a lot of college-aged youth, and transitional age youth, ages 18 to 26, who are transitioning from like adolescence to young adulthood. And a lot of them are just experimenting with different substances, and it might be nicotine, it might be alcohol, it might be cannabis, cocaine, some of the harder stuff, methamphetamines. And sometimes it's just something like that sparks this manic or psychotic episode where they're no longer in touch with reality. They're not sleeping anymore. They're a lot more grandiose and impulsive and with like a mood that's really out of touch with what their baseline mood is, more elevated, more euphoric or irritable. And we try to find out, was it the substance, or is this just unmasking what was already there? Like some type of family history of bipolar disorder. That's why I try to get in that initial consultation, things like family history, developmental history, to know what the genetic risk is. But it can be tough to go back and forth on that. And you just have to get a pattern and clear understanding of what that person is using, how often they use it, what the potency is of it. But even a one-time use of a substance can sometimes trigger a manic episode in certain patients.
Yeah, one of the things I'm scared of is for my son, he's ready to go into high school, and high school kids, they have access to drugs. It's like you go to high school, drugs just automatically fall out people's pockets, right?
Yeah,
And
we saw that with Tiger Woods, right? I saw a couple
right,
of those.
exactly. And as someone with bipolar disorder, I feel like I've had drug-induced mania episodes, not intentionally, but before you know what you know, things happen. I'm scared that he might have a drug-induced manic episode. And how do you have that conversation with, you said you work with adolescents and children. How do you have conversations with them about psychiatric disorders in general?
Well, I let them know that, there are a lot of people that are just walking around with anxiety disorders, depressive disorders, ADHD, autism spectrum disorder. They might just be undiagnosed, right? And it's important to get the help that you need so that we can give you the right supports. But when you add substance use on top of that, you might be adding more fuel to that fire, right? If the brain is already on fire and now you're adding more substances to that, it complicates the picture. And even marijuana, which seems benign to a lot of people are like, oh, it's way less harmful than alcohol. And like, it's just a little weed. It's going to chill you out. Like there's a lot of studies that show that the THC content is way higher than it used to be back in the 70s and 80s. The edibles, the dab pens, all of that can trigger psychosis. So to talk with them about diagnosis, I don't just jump to diagnosis, but I review with them that you can have pretty significantly altered mental status by using some of this stuff. And if you already have an underlying baseline depression or agitation or impulsivity, that this could make that much worse.
Yeah, let's talk about making it worse. You have people who like the way they feel. They like it when it gets bad, right? They say this is just them being their natural selves. They like the grandiosity. They like the impulsiveness, the carefree life. How do you get them to understand that that's not quote unquote normal?
Well, what we look at is that even though they may like some of that high feeling, it's not representative of reality and it's abnormal and it's also not sustainable. It's kind of like a house of cards that you're standing on, right? So it's just waiting for that right moment to topple over. And that's when we see patients getting hospitalized against their will. We see them doing things that they later regret, maybe ruining marriages or spending a lot of money or gambling or engaging in high risk behaviors that they otherwise wouldn't have. So even though that feeling might be there of like, yeah, I feel awesome, I'm on cloud 9, it's very fleeting and it's associated with a lot of instability. So, if somebody is already so far gone, they're not really going to have that insight to know. So you kind of have to capture it early on and build that trust with them, which is why it's important to have a relationship already in place with your psychiatrist to be able to manage that and monitor that. And I do have quite a few patients that have bipolar disorder, bipolar 1, bipolar 2. They might also have some substance use disorders on top of that. And we have these conversations all the time. It's about maintenance, knowing what their baseline is, being able to create the right environment for them that's lower stress, and helping them to see that, like, this doesn't have to hold you back. It can, but it doesn't have to with the right supports in place.
Yeah, sometimes I wake up and say to myself, I don't have bipolar disorder because I feel like my life is together, right? Even before medication, I went to work, right? And I never got fired. Well, kind of one time, but
Kind of
I had
okay.
nothing. Maybe that was the bipolar disorder. Why? But that's a different story. But for the most part, professionally, I always say like I can't be touched. I'm helping writing a book. I'm doing all these great things, but my personal life was in shambles. So it was like I was living two different lives where the bipolar disorder was impacting my personal life, but wasn't impacting my professional life. Do you see that happen a lot in certain patients where their lives were like separate?
Yeah. Yeah, certainly. And thanks for sharing that, Jerome. I mean, it sounds like you've dealt with quite a bit with that. And like each person is different. I've seen it really affect the personal side more first because patients are able to keep it more private and they're able to just maintain that structure and routine that work gives them. Usually, there probably are some soft signs that the employer is noticing, but it's not rising to the level of like any sort of performance improvement plan or like any HR concerns. But on the personal side, when people are a little bit more relaxed and impulsive, I think you can see real changes in like sleep patterns and how the relationships are going and in other types of behaviors. Yeah, I've certainly seen like a compartmentalization like you're describing, but I think eventually if the symptoms get worse, it just permeates everything. So it depends on when you catch it, um, and how you intervene. If it's left untreated in some circumstances, I feel like it will bleed into work and it will bleed into the personal side, the professional side. It'll affect a lot.
Speaking of treatment, I'm very public with my diagnosis. My dissertation is on bipolar disorder. So
Oh,
if
that's great.
someone was to look me up, it's like the fourth or fifth thing they'll find. So it's just like I can't hide from it. So when I give interviews or speeches, like I talk about it. But I have a lot of people who say to me, they say, Gerron, I can relate to everything you're going through. I'm like, hey, seek help. But they're like, I'm scared to because what if they diagnose me? I don't want that diagnosis to follow me. So, what are some things you say to people who are scared to seek help?
Yeah. I would say like rather than worrying about the diagnosis, think about what you're going through and what might be available to you on the other side in terms of treatment, right? Because you're already taking risk when you don't seek help, right? It's not about just the risk of seeking help and having somebody label you as something. It's about the risk that you take by not getting the help, right? The risk of having an episode, the risk of potentially having a legal issue related to untreated mental health, which nobody ascribes to mental health because you're not under the care of a doctor. So if something happens, even being a person of color, we're more likely to have issues with law enforcement, as we've seen, right? Especially if we're showing any sort of unstable behavior. So I would say that what I say to them is like, um, where you're coming from is completely understandable. And, especially given the history and the mistrust that a lot of Black folks have towards medical institutions. So I would just say to them, hey, let's just have a conversation about things. And the diagnosis piece is completely confidential. Unless you're trying to get into like the military or something or the Secret Service, then obviously that gets revealed. But other than that, it's protected by HIPAA. It's confidential.
Mm. You know, I think it's a great reason not to go to the military personally. They just expanded the age to 42. And I'm just like, look, if you don't want to go to the military, get diagnosed because we good. Like I can't join, and I'm also amputee. I couldn't join anyway. But
Oh, okay.
nonetheless, like they're not gonna take me. And I'm just like, yay, good. Don't take me. But
Don't take me. Yeah.
no, seriously, don't take me. I would not be a good fit in the military. I don't have the heart. I don't have the heart to be mean to anyone. Not a mean person.
Yeah.
But let's talk about that mistrust. And I think that mistrust is 100% justified, right? If you look at the history of the medical system and what it's done to Black people, it's
Yeah.
it's terrible. So
It is
how
terrible.
do you as a doctor, how did you come to terms with that mistrust and knowing that when Black patients see you, they have to see you both as a Black man who's trying to help them, but they also see you as part of a system that has been designed with their best interests not in mind?
Yeah. Well, I first acknowledge that there has been that history of mistreatment. And, when you look at the Tuskegee uh, treatments, everything that went on with that, with the syphilis studies, when you look at how Black bodies and people were used for experimenting with surgery, when you look at, there's countless examples, right? So being used for clinical trials without any informed consent. The list just goes on and on. So I could see how that mistrust is there. And I just acknowledge that and say, hey, this is real. I validate that experience. I don't try to argue with them on that. And then I just take things slow. I slow it down. The way my practice is set up is I really uh, give patients the space and the comfort to open up about things. I don't pressure them to talk about any one thing, and we say, hey, we can get this over time as we get to know each other and build that therapeutic alliance. So that's kind of how I explain that to them. And I say, like, I'm not here to force you to do anything. You're coming in of your own will. That's kind of what I like about the outpatient work as opposed to the hospital-based work that I do where I work in the emergency department doing emergency psychiatric evaluations. In my outpatient sector, we can take things much more slowly, um, depending on how the patient is doing and feeling. And if they come back for a second appointment, I consider that a win because that means they trust me enough to see me again. And I build it that way.
You just said a lot of gems there. The first one I want to talk about is the term alliance. I love that because it is an alliance. You're working together to help someone achieve stability, help them achieve their goals, help them achieve becoming their best selves. Another thing that you touched upon, which I want to get into right now, is you said you see emergency patients as well as outpatients. And
Yeah.
tell me the difference between the two. Like, what happens when you see someone in an emergency situation versus when you see someone in an outpatient situation?
Oh, yeah. They're very different. There's certain elements that are the same. You're still wearing your clinician hat and trying to think about who that patient is. But in the emergency setting, I work at Mass General Hospital in the emergency department in our acute psychiatry service. I was the chief resident in my 4th year of residency there. And then I just continued working there as an attending since 2017, pretty much. 2017 to 2019. So I've been kind of doing the evaluations for a while, supervising the residents there. And I would say the biggest difference is that in the ER, you're pretty much seeing anybody and everybody that walks in, whether they have insurance, no insurance, regardless of the socioeconomic status, Black, white, Asian, whatever. And you are also dealing with more complexity, medically as well as psychiatrically. People can come in with dementia or delirium or with a stroke or with substance-induced mania or psychosis, right? And they can be sent from the jail to the ER. They can be sent from the court. They can be sent from the Boston Logan Airport, which we get a lot of, right? They can come in hot and agitated with suicidal ideation and with homicidal ideation, or they can come in just voluntarily, coming in, taking the train in. We see homeless people. We see people that are wealthy and donors to the hospital. So it's really diverse. I would say the biggest difference is like you have to be prepared for pretty much anything that walks in. Um, and you have to have compassion in a way that really transcends everything in the ER. But you also have to be very efficient and tight with your evaluations because we don't have as much time because we're seeing such a high volume of patients. So I find that it's rewarding because you're getting to see a lot and do a lot and you're helping so many different people, but it can also be taxing because you're trying to move so quickly and you're not really getting to know that patient over time. You're just seeing them and making a level of care assessment and a safety assessment. Like, are they going to go inpatient? Are they going to go outpatient? Are they going to do a day program or a partial program? Am I going to send them for a detox? But then you're pretty much seeing them and sending them on your merry way and signing out to the next person. Whereas in the outpatient world, it's more longitudinal. I get to know these people over time. They send me Christmas cards. They send me, you know, New Year's cards, things like that. You know, it's a relationship that we're building. It's not just like seeing them when they're in crisis. Whereas the emergency department, I do love the work there, but you're seeing people in crisis. Whereas in the outpatient world, I get to see them and know them over time as people more. They don't feel like just a number to me. And I value the relationship in a different way in the sense that like I get to know them. So I feel like you have a chance to have a greater impact on somebody's life than the outpatient side of things because you're getting to know them through the thick and the thin, and you can take your time to really give them the custom tailored treatment that they need and go from there.
I dig it. Earlier you talked about psychotherapy combined with the psychiatry. Can you expand on that a little more and talk about how that differs from just normal psychiatrist practice?
Yeah, I mean, it depends on how you define normal, but I think in my training and with a lot of my supervisors, uh, what I learned is that like taking an integrative holistic approach can be more helpful to the patient, right? We want to advance them towards their goals and towards healing faster. And I felt that with the psychotherapy training that I had in residency, that I would be doing a disservice if I didn't offer them that, you know, talk therapy, focusing on coping skills, focusing on challenging negative thinking traps, focusing on building skills, right? So what I do is in my practice, that's more of me seeing the patients. What I do is we do 50-minute sessions, 50, and we integrate the medication management with the psychotherapy. So there might be a patient that's not necessarily on medications. We might spend more time doing therapy. We might decide to start an antidepressant like 2 months into the therapy, realizing that, hey, I think you would really benefit from medication at this point to just provide a little more foundation while we build these tools. And then I continue to follow up on the medication, see if any tweaks are needed while we also continue working on building coping skills. And I just feel like the way a lot of traditional psychiatry has been practiced is just prescribing medications and just seeing patients in 15 to 20-minute increments because you can collect more by seeing more patients in a shorter period of time. So a lot of these places that become effectively pill mills just will see patients over a very short period of time and be like, hey, I can see 3 or 4 patients in an hour as opposed to seeing 1 in an hour. And that's a model that may work for some people. That's what they're looking for. They're just looking for a refill on their Adderall, or like maybe, you know, they're trying to see more people and access more in the community. But for me, that didn't feel satisfying, and I didn't feel like I was really getting to know people or make more of an impact. So I set my practice up the way that I wanted to have it, which was more time with patients, more holistic care, less overall patient volume, and more quality time, in my opinion, with each patient.
I think that quality time is important because who doesn't love quality time with someone and showing someone that you care about them on a deeper level than just saying, here, take this medication. You know, here's a follow up. Are you alive? Do you have suicidal ideation? No, no, yes, you're alive. No, you don't want to kill yourself. Here, take this next. Here's your refill. I think that's extremely important to keep building that rapport, keep being a person of care for that person. That's really great. Speaking of medication, I often get told, they say, Gerron, I don't want to take the medication. I'm scared. So, how does that conversation go with someone who's starting medication?
Yeah, I mean, I get that all the time. If they're willing even to tell me that, sometimes they'll just take the prescription and flush it down the toilet and won't tell me until 3 months
Mm,
later that they weren't taking it. So it's good if people are bringing that up early on, because then we can have a discussion about what the risks are, what the benefits are, what the alternatives are. And I take that as an opportunity to explore with the person, like, you know, where are these fears coming from? And what are some of the things that you're worried about? And take it seriously, walk through with them what are the different things that they're worried about, not so I can just try to convince them otherwise, but so that we can understand together where the worries are. People Google stuff all the time. They're like, hey, this is going to make me fat. This is going to make me stupid. This is going to cause diabetes. This is going to slow down my athletic performance in hockey, in baseball, in football, in basketball. This is going to make me, you know, more numb and not be able to feel my emotions and make me be more blunted or make me a zombie. There's a lot of valid concerns that people have, or it's going to cause sexual dysfunction. I'm not going to be able to perform. So I review all of these different concerns that people have and assure them that together we're going to monitor for any side effects and try to make the best possible choice about if first of all, if they should even go on medication or if we should continue focusing more on the therapy. And also if there's other complementary and alternative agents that we can use that they might be less worried about.
definitely. I also, to be honest with you, some days I'm like, am I cured? Do I no longer have bipolar disorder? Like, because I feel good, right? I'm not impulsive. I'm not hypersexual. I'm making good decisions, right? I'm just quote unquote normal. Like, I don't know what normal means,
Yeah.
but like sometimes I'm like, I feel it. Like, I ask my friends, like, hey, can you tell me what it is that you normally do on a day to day? What are your normal emotions? And they look at me like I'm crazy. And I'm like, no, I'm serious because I don't know what it means. And I need to know because I think I feel that. And I'm just like, if I feel that way, I just want to stop taking my medication. But in the back of my mind, I'm like, I know enough about this. It's because I'm taking my medication that I feel this way. I'm informed enough that I know, but there are people who aren't informed enough to know that. So do you get people who are just like, well, I'm taking my medication, I feel good, so I'm going to stop it? And if so, what do you normally say to those people so they continue to take their medication?
Oh, yeah. It happens all the time, Jerron. So I appreciate you bringing that up. And it's not just people that are informed or misinformed that do that. I mean, everybody does it at some point. They're like, oh, do I really need this medication? W- do I really have an issue? Do I really have bipolar disorder? Like, I'm feeling better. What's the point of taking the medication? You're naturally going to see that. And not everyone needs to be on medications for life. So it's a natural curiosity that people have. What I say to them is that this should be a discussion that you have with your doctor, not just something that you take yourself off of, so that we can make an informed decision about how to taper it or if we should taper it and do it in the safest way or not, stay on it. And what I tell them is that, like, based on maybe your history of symptoms, you did meet the criteria for that particular diagnosis. And sometimes people can go into remission where they no longer have symptoms of that particular disorder. Does that mean they never had the disorder? No, but it might be that, they're in remission now, not experiencing the same life stressors. Maybe they've built other coping skills that have kept this at bay. So it is possible. Um, but I usually don't say, well, you no longer have this anymore, but rather, uh, it sounds like your life circumstances have changed and things are moving in a different direction. Let's talk about how we can make sure that you're fully equipped.
I love that. I love the language you're using. I can tell that your patients really love coming to you. That's really
I mean,
good.
I don't know about all of them. I mean, I try, I mean, you're not going to connect with everybody, but if I can connect with some people and make a difference in someone's day, I'm happy with that.
One a day. I think in my profession, we just say one student a day. If we can impact one student a day, we're good. So
Yeah.
hopefully it's similar in yours.
Yeah, absolutely.
So one of the things you mentioned was making people feel dull, like a zombie. So that is a stereotype. That is a concern. I know one of my concerns when I was taking medicine was, how are my emotions going to feel? Am I going to be a zombie? Am I going to be too emotional? Am I going to be too sad, too happy, too anything? When I first started, I started on Lamictal. I'm still on Lamictal. Thank God
Yeah.
it's worked for me. But I felt like when I first started it, I didn't start antidepressant till later on in treatment. I did lose some of that emotional connection where I would be at a funeral and I felt like I wasn't sad enough, right? I would just be like, well, I'm sad on the inside, but like I can't produce tears. Then, you know, but then I realized that necessarily, I don't know if that was the lamictal or if that was just me no longer being sad at funerals in general. So how do you balance some of those life changes with some of the medicine changes?
Yeah, it's complicated, right? Because any given medication can cause any given side effect in any given person. That's what I always say, right? So, like, just because the statistical manuals and the clinical trials manuals say that, oh, this side effect only happens in 0.1% of all patients in the clinical trials, that could still be that person who's experiencing that side effect. So we always look at these concerns seriously. But I do commonly get that people bring that up, that, I'm not able to produce those tears or feel the adequate sadness that I should be feeling. And that's pretty common, not just from what I've heard from Lamictal, but also from like some of the antidepressants like Zoloft and Prozac. And so I think we have to look at what the person is actually getting out of it. What are the benefits that they're getting? And is this issue that they're noticing of like not being able to cry or express their sadness in the way that they would like, how is that holding them back? Is it worth potentially lowering the dose of the medication or switching it to another medication? And we try to determine together, is this an actual side effect or is this just like some random situational thing about this funeral? Not everybody expresses their grief and sadness in the same way. A lot of Black men, we may not cry or show vulnerability in that way, or we might internalize it, or it might come out later in private or at a different time. The grief might not necessarily be openly displayed in that manner. But that doesn't mean that we don't feel it on the inside. So, I would first want to make sure that that's an actual side effect and not just like a one-off thing, and track the symptoms, like maybe through journaling.
Definitely, because I was thinking it may be one off because when I first started it, I cried every day for like 2 months. And I was low. I thought about every hurtful thing I've ever done. Um, as a mood stabilizer, and it was bringing me down from the grandiosity of my life, and I was living life on such a high for months and years at a time, and it's just like, wow, I couldn't believe how I was living, right? And it was shocking, the things I was doing, right? The hypersexuality, the impulsiveness, the money spending, right? The like, fuck it, as long as my rent is paid, right? The rest of the money doesn't matter. My bills are paid. I can just spend it, right? The credit card swiping,
That's
right?
right. Get it done.
Right. It's done. My bills are paid, so what does it matter, right? I'll
That's
get
a good
another
question.
paycheck.
You were getting the bills paid. Yeah. How are you doing that? You were paying the bills, and I guess you still had a lot of extra money in the bank.
No, I was just spending whatever money was left.
Oh,
So So
Yeah.
it was it was a time, but I think when I started the antidepressant, it did help balance that out. And I think the antidepressant did make me feel a lot better. I started on Lexapro,
Okay.
then I switched to something else, then to something else. Now I'm on Rexulti, and
Yeah.
I feel great. I think shout out to Rexulti, the makers of that. If I can be a spokesperson, sponsor the podcast Rexulti. Like we're great.
There you go. Just got to find the right combination, the right cocktail of medications that are really going to help you to create that chemical balance. And that's going to be different for different people, you know?
Exactly. I think it's so important for people to just find what works for them and to keep trying, because I think I'm on my fourth or fifth combination. Lamictal has been with me throughout the journey, but the antidepressant has changed about 4 or 5 times, because I think it was Lexapro. I just gave up on trying to lose weight on Lexapro. I switched it and the weight fell off.
Wow.
So
Hey, see, yeah, that's amazing. You know, some people are going to not gain any weight on that. Some people will. So you got to see how it impacts you and monitor that with your doctor.
definitely. We love this thing. You said you go to church every week.
I
We
tried it.
love to we love to pray it away in the Black community, right? I've seen many times in church, if you got depression, come on up. We're going to pray it away. And I believe there's a place in prayer. I'm a faithful church goer as well. Try to go as much as I can. But I also believe in medication. How do you balance that out when you're talking to a client like who's avid, like, oh, I can just go to church versus medication?
Yeah, I think that's a great question. I mean, first of all, I never position the medication or the science against the faith as if it's like two things competing against each other. I first dismantle that sort of diametrically opposed confrontation that people sometimes want to create. It's not either or, it's both and. In looking at the medication can help kind of create that space for you to access your faith more by helping you to just nourish your soul a little bit better, right? The medication is one aspect of the treatment. It's one of the many tools that we can use, right? Psychotherapy or talk therapy is a way to open more doors too. Look at what a lot of priests do and pastors. A lot of them are doing outside of their regular work on Sunday services. They're doing a lot of counseling and ministry in the community. What do you think that is? That's not just them talking about whatever, they're actually counseling people. And so on the mental health side, we're just wearing a more clinical hat. And so I think many people are already accessing that in terms of like just praying it away. Going back to the medical analogy, certainly I'm all for prayer. I think we should be doing a lot more of it in our daily lives. But just like if a patient is coming in with cancer or diabetes, for example, do you offer them the insulin or do you just tell them to pray it away instead of giving them the insulin, right? You say, do both. Take your insulin for your diabetes and pray about your diabetes, right? Do both. I don't say either or. Same with maybe a cancer patient, yes, certainly pray, but also, go see your doctor in tandem, get on the right chemotherapy or radiation regimen that you need to get the right treatment in place. Because these are two things that can work together synergistically. It's not about either or. God gave us the tools and the wisdom and understanding to access the science and the technology to be able to help ourselves in the best way that we can. He doesn't want us to not use those tools. That's why he gave us the creativity and knowledge to access them.
I 100% believe that God gave us access to these tools for a reason. If it is not the devil, it is God-given tools, right? If God did not want us to access the tools, he would not have given us access to these tools.
Exactly.
I agree 100% with that statement. So just thinking about how you approach and how you present yourself in your office to patients, specifically your young patients, how do you make sure that they're comfortable?
Yeah, I mean, I see a lot of folks. I mean, the youngest patient is probably like has been like 3 or 4 years old. So, um, with like ADHD or autism spectrum disorder. So it depends on the age group that you're working with, male, female, trans, non-binary, uh, adult, child, adolescent. I think, you have to see kind of what the profile is of the person that you're working with and what conditions they're being treated for. But in general, I try to create an open, safe space for that individual in my office. I have a lot of toys, a lot of games in my office. Um, a lot of it's tucked away in drawers. I got stuffed animals, fidget toys, Legos. I got the Titanic that you can't see up there. It's 9,900 pieces or something. Put that together with one of my patients. We'll talk about stuff that's not even clinical. We'll talk about sports, the NCAA tournament, March Madness. Just try to find anything that we can really connect with each other on to just open things up and allow some breathing room. Because in psychiatry, like, we don't take like x-rays of people or MRIs. Our personality as psychiatrists is our MRI machine. How we interact with patients and how they respond back to us in the feeling that we have, the transference and the countertransference. That is the MRI machine that allows us to see within about what's going on. So if you don't have that relationship that you're building and you're not creating this sort of trusting relationship in the room, you're not going to be able to really see what's going on. I might have the best textbook knowledge and be like, yeah, I know exactly the right medicine to put you on and the exact right treatment plan. But if that trust is not there, you haven't helped them to feel comfortable about sharing what their fears are, what their concerns are, what their goals are, it's not going to land. And you might as well have not even been able to bring it up. So I think all of that's important.
First of all, your analogies and metaphors are so on point. I'm going to steal them. I don't know how I'm going to steal them and repurpose them, but I'm going to steal them. Now that New England is starting to thaw a little bit from this very, very cold winter you all had, what is one thing you're looking to forward in the summer, spring and summer?
Oh yeah, there's a lot of things I'm looking forward to. I'm looking forward to just being outside, being able to wear a t-shirt and shorts and not having to worry about taking my jacket. I'm looking forward to going on nice jogs around the lake. We got a really nice lake around here that I like to run around and, being able to walk with my daughter outside and run and, jump on the trampoline in the backyard with her. She's 3 going on 4. So, and I think we'll just enjoy going to the park and going to the dog park and things like that. So I'm really looking forward to that.
Nice. That sounds lovely and wonderful. I will
Yeah.
be sending some sunshine up your way so it's not 90 degrees here every day.
Hey.
Hopefully you get some sunshine. So now's the time of the podcast where I turn it over to you so you can ask me any questions.
Yeah, absolutely. And thanks for sharing your story, Gerron. So tell me a little bit more about what you do and how your diagnosis impacts like your day-to-day life.
So I'm a director of advising at a university in the Southeast. Um, and how it impacts me is it just pre-diagnosis. I think I describe my life in pre-diagnosis and post-diagnosis. Pre-diagnosis, it just impacted, I think, a lot of my personal relationships with people, specifically women. I would date someone, fall madly in love with them, then I would just basically just, ghost them, cheat or do whatever. And it's just like, I could never figure out why. Cause it's like, I truly love these people. And it's just like,
Hmm.
I don't understand what was happening. And then I would just slip into this dark depression for weeks. And I would just not speak to them. Then I would just bounce back like nothing ever happened. And I would repeat this cycle over and over and over again for years till one day someone was like, hey, this isn't normal behavior. What you're doing just, it isn't normal. Then on top of that, the impulsiveness, the grandiosity, all these things, they were just like, hey, like, you should talk to someone about this. And I already was in therapy for years. I'm a strong believer in getting and seeking help. So I was like, okay, let's talk to psychiatrists. Let's get some more deeper help, because obviously therapy isn't working to the extent that I need it to work, because I'm still doing the same thing. So that's when I got diagnosed.
Oh, I see. I see. Interesting. Yeah. So you were able to get some extra help there. And like, um, so do you think being black, being a person of color plays into any of like how you interact with like the mental health field or with like, your symptoms?
Absolutely. When I was looking up bipolar disorder in black men, there's absolutely maybe very little research on black men and bipolar disorder. Very little. Maybe there's more now, but when I was writing my dissertation, I could hardly find any. And bipolar is a very well studied disorder, very well known. If you look on research, they even talk about it's present in the Bible, right? But it's not well studied on black men, and specifically, it's not well studied in collegiate students in general. So, and I think it's harder for black men to be seen as bipolar disorder. And my study and my area of expertise is college students, specifically black male college students. So
That's great.
one of my goals and areas of expertise is to really look at the intersectionality of black men, because I feel like oftentimes they just want black men into one group and say, hey, we're going to create a black male initiative, and say, they're going to figure it out. We're going to put all the black men together, no matter what the other identities are. We're going to say, if they don't graduate, it's because they didn't want to graduate, not because they had anything else going on.
Right. Yeah, that's a really good point, lumping it together. And I work with a lot of young adults too, who are in college. And I think it's a very interesting time where there's all sorts of stressors going on. You got college and academics, you're trying to still figure out your identity and who your friend group is, and turning to your friends increasingly for social support rather than family, and then trying to figure out how to be more independent. So you're in a bubble in college, but it's a very stressful sort of bubble as you figure things out. And then, you know, being being black as well in an environment where, you might be misdiagnosed, or you might be understudied, right? And why is that? I'm curious, that why are there less research studies on African Americans when it comes to bipolar disorder? Like when I think about my work clinically, you're right. I mean, like out of my patients with bipolar disorder, not a lot of them are black. And I wonder what that's about, you know?
I think one, people can be misdiagnosed sometimes. Two, black men don't have the resources or don't understand the resources that they have. And three, I think there's just not an emphasis. It's not an area of emphasis for a lot of people. It's not a topic of interest. The research interest isn't there, right? That's not where not necessarily the money is, but that's not where people's bread and butter is. They're looking at, black male success, right, from a different angle, or black male from that deficit lens, more so like, hey, why aren't black men succeeding? But there's not really from a mental health standpoint, right? It's always an environmental standpoint. They're not succeeding because they come from broken homes or this, right? It's never because of a mental health condition.
And you would ask me kind of what my treatment philosophy is. I'm curious, like what you really look for in a provider. Like,
I think
what,
for me, someone who's going to be patient, I don't like the 20-minute appointments. I'm not going to lie. I do understand that people do have to get through them. And both the psychiatrists I had, one, the intake was a little longer. Some of the meetings were a little longer in the first one, but I do understand, like with the second one, like, hey, I'm comfortable having the 20-minute appointments, but I don't like them. I don't like these short appointments. I think they do a disservice because you're not really getting to know the patient. You're getting to know the symptom, and you're getting to know what it is, and you're just relying on your own knowledge of the disorder or or whatever it is that the patient has. You're not really getting to know how it personally impacts the patient besides in that first 10-minute conversation. This has been another episode of Black and Diagnosed. I was here with Stephen. Thank you so much for being here with us today. You dropped some gems. We got some analogies and metaphors that we're going to steal and use. Thank you so much.
Thank you, Gerron. I really appreciate the time chatting with you, and it's been great.
That's our time in the garden today. If this conversation resonated with you, or if it helped you feel a little less alone in the fog, please share it with someone who needs to hear it. This has been Black and Diagnosed with Gerron Scott. If you'd like to contact me or share your story, you can reach me on Instagram at g.scott, GDOTSCOTT, or info@gerronscott.com. Make sure you subscribe to get the newest episodes when they drop. Be well, and I'll see you back in the garden soon.